good words and for giving me the opportunity to liaise with such a large society as the Indian Endocrine Society. And what I was asked to do and what I hope that I can do the next 25 minutes is to give you an overview of the management of functioning neuroendocrine tumors. And this is an outline of my talk. I'm just going to discuss carcinoid syndrome and pay some special attention to carcinoid crisis, a few words about carcinoid heart disease. And then I'm going to expand on functioning neuroendocrine tumors, the most common ones, and then discuss about the ectopic hormonal syndromes roughly, and then hopefully reach a conclusion. So we do know that neuroendocrine neoplasms have the capacity of synthesizing and secreting substances that, when bioactive, they can cause distinct clinical syndromes. So the rationale of treatment in these patients is treatment against the tumors, so trying to minimize the effect of the expansion of the tumor and thus the secretory component. And if this is not feasible, counteract the action of the secretory component to target organs. The same applies when they have ectopic secretion of hormones and the target organs are other endocrine glands. And of course, this is done in the context of the multidisciplinary team. So coming now to carcinoid syndrome, because gastrointestinal neuroendocrine tumors are the commonest neuroendocrine tumors, and we do know that patients that we have, they have neuroendocrine tumors, particularly of the small bowel, they can develop in about 20 to 30% of them this relatively devastating syndrome, which is constituted of symptoms affecting the gastrointestinal syndrome with system with a secretory diarrhea and the characteristic rash and typical flush, as you can see in this part of the slide. Very occasionally, this can be atypical if other compounds are secreted. And sometimes we have symptoms from the respiratory system as well. So the rationale of developing this syndrome is that you have bioactive compounds, particularly secreted from the small intestine, although sometimes this can happen from other tumors that they can bypass the liver. And this is very important because one of the compounds which is responsible for the syndrome, serotonin, is not metabolized in the liver and therefore can exert its effect. And this can occasionally, sometimes you have quite a lot of mesenteric metastasis. And as you can see from this slide, 5-HTP or serotonin is one responsible for the diarrhea, and you have another a set of compounds that can cause the other symptoms. Hopefully, these tumors have the ability of expressing in the cell surface somatostatin receptors. And this is, as you can see here, this is the distribution of the expression of the receptors in this particular neoplasm. And we can utilize that because we know that somatostatin, which is a compound that is widely expressed into the body, found into the body, it can inhibit the secretion of these compounds as well, and they reduce the synthesis, and as well can affect the motility of the bowel. Native somatostatin have a short half-life of a few minutes. Therefore, some bioactive compounds with a relatively longer half-life have been synthesized. The first one was octreotide, and then it was lanreotide. Initially, that was done in long-acting release, and now we can use these compounds for the treatment of this syndrome. And in this, acting through this receptor, these compounds, either in the subcutaneous form of administration or in the long-acting administration, particularly octreotide, have been quite efficacious, as you can see, in controlling both diarrhea as well as the flushing. And these have been used for quite a long period of time. In a review and an analysis that was done 10 years ago, Professor Modlin from Yale has put all the data together and has found that approximately 70% of the patients can respond in relation to reduction of control of the symptoms in these compounds, both octreotide and lanreotide. And these data have been replicated again from the big series from the Royal Free Hospital a few years ago. However, about 30% of the patients, they're still not well controlled, and this can be higher if the secretion of serotonin and the 5-HI levels are extremely high. Although initially that was thought to be a relation to tachyphylaxis, now we do know that is secondary to the tumor burden and the amount of secretory component, and therefore other options are utilized in order to try and control the symptoms. And this is either increasing the dose of the somatostatin analog or giving top-up doses subcutaneous administration. And as you can see from this slide, interferon has been shown to have an effect in reducing the level of 5-HIA and controlling the symptoms. Then a synergistic action of somatostatin analogs and interferon, new developed somatostatin analogs, other drugs, and of course, cytoreduction, which means all the means that we can employ in order to try and reduce the tumor bulk, either surgically or cytoreductive techniques or medically. So because of the action of both somatostatin analogs and interferon, 2 randomized studies have looked in the past whether these compounds in combination can have an effect not only the control of the symptoms, but also the control of tumor growth as well. But unfortunately, these were retrospective, although the retrospective analysis of the symptoms did not allow any solid conclusions, although it was some evidence that maybe interferon along with lanreotide could control a little bit the symptoms. But however, these compounds have quite a lot of side effects, so they can be used, but not as first-line treatment. So the next obvious solution was to see if they can try and increase the dose of the somatostatin analogs in order to saturate as much as possible somatostatin receptors. And this had an effect in either tumor growth or try and control the symptoms that they were not controlled with the traditional doses. And most of the data are retrospective, so there's no quantitative measurement of the effect of diarrhea and flancing, but as you can see, several studies have increased the dose of somatostatin analogs utilized up to 40, 60 milligrams, or even the interval of the dosing, and doses up to 120 milligrams have been used. And these have been shown, although retrospectively, to have an effect in controlling the diarrhea and the flushing that they were not controlled with the conventional doses. Further studies were done to show this effect, but again, they were hampered by the retrospective nature. We do know that relative newer somatostatin analogs like pancreatic have been developed, which have a more wide expression in controlling the somatostatin receptors. And in this phase 2 study, patients that they were not controlling the conventional dose of octreotide LAR were given subcutaneous pancreatic in increasing doses, and there was a 30% reduction of the symptoms of the carcinoid syndrome that were not controlled with the conventional dose. Therefore, as you can see in this slide, therefore a phase 3 study was organized where there was a face-to-face comparison of 60 milligrams of pancreatic to the 40 milligrams of octreotide, and the conventional dose is 30 milligrams. So that was a 1:1 randomization. And if patients that were not responding to octreotide LAR, they were crossed over to pancreatide. And in that study, there were more subjective other means to try and assess the response to bowel movements in diarrhea and the flushing episodes. But as you can see, there was an overall similar response to these compounds, and there was an overall 21 improvement. So it seems that by increasing the dose of at least octreotide and because the class effect lanreotide, you can achieve control, and the control is not as high as the retrospective studies have shown. And this is the maximal mean effect that they had on these symptoms, these medications used. Another way of trying and reduce the compound that is responsible for at least the devastating diarrhea is try and reduce the synthesis of serotonin by utilizing inhibitors and that on the tryptophan hydroxylase, which is the enzyme that converts tryptophan to serotonin. This has been tried in the past, but these compounds were crossing the blood-brain barrier, and they were causing a lot of side effects. The Lotristad is a compound that does not have these side effects, and in an initial dose phase 2 study that it was tried in 23 patients in escalating doses, in patients that they had not control diarrhea and flushing, particularly diarrhea on a conventional dose of octreotide LAR, it showed that there has a response in bowel movements and in the 5-HI levels as well. Therefore, another study was organized where they looked at incremental doses of this compound, and they very well tried to assess the response to treatment by saying that it's less than 4 bowel movements per day and decrease at least 50% in the flushing episodes. And they look at the stool quality as well. And as you can see, all the patients that they received this medication in different doses, they had a substantial response. And in bowel movements and about 50% response, but there were no data regarding what was the maximum tolerated dose and what was the incidence of side effects. Therefore, a phase 3 study developed, which looked at patients that they had received placebo, although they had unresponsive diarrhea to conventional dose of somatostatin analogs, octreotide LAR, either 250 milligrams 3 times a day of telotristat or 500 milligrams 3 times a day. And the primary endpoint was the control of the symptoms. And as you can see, in comparison to placebo, patients that they received the 250 and the 500 milligram, they had at least minus 1.7 and 2.1 reduction of the diarrhea. And this is the flow chart as well. And recently there was a publication where they assessed all the patients that they had received this medication, and the mean duration of exposure was 1.3 years. And it seems that control of the diarrhea that is particularly diarrhea that is obtained with this compound improves in nutrition, and these patients can put on some weight, and the side effect profile is quite beneficial, and the survival rates are favorable. However, we do know that there are other causes as well that they can contribute to the diarrhea. And of course, we can use conventional pills to try and control the diarrhea before the effect of medication that we're utilizing. And the ones that we use are loperamide, we can go up to 8 milligrams, or morphine analogs. We have to take into consideration that because of the secretory component, these patients may develop deficiency vitamins, so we have to replace that. And because of the somatostatin analogs, they may developed deficiencies in pancreatic enzymes. There is some data that descentron that acts on somatostatin receptor 3 may have a specific effect, but this has not been replicated. And of course, we do know that in patients that they had surgery, they have to take into consideration potentially of bacterial growth in the remnant of the bowel, and they have to prescribe antibiotics. And of course, there may be bile acid loss and deconjugation, and they respond to cholestyramine. Another problem with patients with carcinoid syndrome is they develop mesenteric fibrosis, which can induce ischemia to the bowel. And in these circumstances, loperamide may be of help. And in case we have other compounds secreted like histamine, then we have to mobilize other drugs as well, and glucocorticoids. And of course, tryptophan, when it's correctly used for the synthesis of serotonin, can induce skin rash and pellagra, and this has to be treated adequately. So although no guidelines exist, in 2016, we tried to put an algorithm how to deal patients that they have carcinoid syndrome not responding to conventional treatment. And of course, as I mentioned, somatostatin analogs are the first drug of choice, but we have to take into consideration all the other things that I just mentioned to you. And then we can increase either the doses of somatostatin analogs and use top-up doses of subcutaneous octreotide. And of course, administer telotristat, that's also is quite efficacious. And then even come to interferon, which, as I told you, we don't use it that much because it's associated with considerable side effects. Of course, pasireotide, it's an option that we can use, and we should never forget that cytoreductive techniques and other means to reduce the tumor load are one of the best ways we have to reduce the amount of the compound secreted. And in this slide, you can see that some of the treatments that we use in order to control tumor growth can also be efficacious. And in this study look at the response of patients that they had in the NETTER-3 study, response to PRRT with 177 lutetium and Lutathera. The reduction of 5-HIA was associated with substantial reduction of the symptoms, particularly diarrhea. Another very important issue that we have to consider is that carcinoid syndrome sometimes can become very deleterious, particularly if it's associated with carcinoid crisis, secondary to the release of excessive amounts of bioactive compound. And this is secondary to several procedures like surgery or chemoembolization or RF ablation or even biopsy or even PRRT. Therefore, we have to avoid these participants because this carcinoid crisis is a very, very important and very severe symptom associated with hypotension, changes in car rhythm, bronchial wheezing and flushing, and central nervous system dysfunction. Therefore, we have to take that in consideration and pre-treat these patients before any of this procedure. And that best way to treat them is by infusion of IV octreotide, and you have to titrate the dose. And doses usually are between 500 and 200 micrograms per hour, but they can go up to 500 micrograms. You can add as well in case there are other compounds secreted, histamine blockers and glucocorticoids. There was an issue about vasopressor agents, whether this could participate further the syndrome, but this in this big study where 127 patients were studied to see whether they were developing a carcinoid crisis, which was defined by systolic blood pressure less than 80 or more than 180 and increased heart rate and organ dysfunction. Still some patients, they develop carcinoid crisis, although they had in administration of octreotide, and however, the presence of carcinoid syndrome and metastasis, hepatic metastasis, have a higher odds ratio in developing that. But vasopressors seem that they reduce the hypotension episodes and they conferred some protection for these patients. Of course, carcinoid heart disease is a very well-known complication of untreated carcinoid syndrome. We did know that in the past, because we didn't have all these medications available, the prevalence was about 50%. Now it's less than 30%, approximately 20%, because we use somatostatin analogs. And these patients, they get fibrosis of the heart valves, particularly the tricuspid valve, and they develop right heart failure. And there are some guidelines that they will produced by the American College of Cardiology, where we have to be sure that we try and reduce the 5-HI levels because there is a correlation with the high values and the development of carcinoid heart disease. And we have to treat them conservatively, and then we have to pay caution when we want to do some procedures because that we have to cover this patient as well. There is an issue about PRRT, and of course at the end we may end offering valve replacement, particularly if severe procedures need to be undertaken like surgery or embolization. So in these slides, there is what NH has come as a consensus for the management of patients with carcinoid syndrome. And of course, we have always to look at the presence of carcinoid heart disease and then treat that vigorously if present, and then identify the risk for carcinoid crisis. Of course, treat all these patients, and if there is an issue of carcinoid crisis, try to cover these patients with the regimen that I showed you previously. Coming on now to the functioning pancreatic neuroendocrine syndromes, European Neuroendocrine Tumor Society has made a simplification because there are many pancreatic neuroendocrine tumors, but the ones that we most commonly see are the insulinomas and the gastrinomas, where you see quite a few cases. And then there are some other rare ones where there are more than 100 cases described, and I'm going to concentrate on vipoma and glucagonoma. We haven't seen that many somatostatinomas per se, and again, sometimes this neoplasm can secrete bioactive compounds that they are not eutopic, they are ectopic, and they have a lot of patients that they can develop ACTH secretion and PTHRP secretion in the relevant syndromes. And then there are some very rare ones that I'm not going to elaborate on them. Of course, we do know that in order to try and control these syndromes, we have to reduce the tumor bulk. That's why it's very important to always consider that and do this if it is feasible. Sometimes if there is extensive disease, this may not be feasible. And if patients, they had a Whipple operation, embolization may be not feasible, or SIRT may be a little bit peculiar to administer. We have to know when to give PRRT, and of course the other medications that I mentioned, and medications that they use that they don't have that much cytoreduction as well. So coming now to the insulinoma, which I think that is going to be extensively covered by the next speaker. We do know that the autonomous secretion of insulin from these tumors can induce retractable hypoglycemias. And then diazoxide is a medication that has been used traditionally for the management of these patients because it acts on the ATP-sensitive calcium challenge by reducing insulin secretion. And many of the insulinomas, approximately 50%, they express in their surface somatostatin receptor. So with the same rationale, somatostatin analogs can be administered to try and inhibit the secretion of insulin from these tumors. Of course, because this can be very devastating. We have to give them frequent meals, high carbohydrate content, and patients have to be on IV glucose infusion, sometimes 10% for quite a long period of time. As I mentioned, somatostatin analogs can be used, but have to be sure that the somatostatin expression is evident in this tumor, because approximately 35 but the new somatostatin analogs, gallium, do not express this receptor. So if we give them octreotide or other somatostatin analogs who may inhibit counter-regulatory hormones, if they don't express the receptors like glucagon, and have even worsening of the hypoglycemias. As I mentioned, diazoxide has been used for quite a considerable period of time. The dose is up to 600 milligrams, and about 50% can control the hypoglycemias, but they can be associated with side effects, and we don't know if there is an effect on tumor growth, probably not. Glucocorticoids can be used, but they have multiple side effects, and they don't perform very well. And the short-term glucagon can also be used, and there are some reports that continuous glucagon infusion. Medications that are mentioned in the literature, like verapamil, phenytoin, and beta blockers, that have not shown to have efficacy, and there are some data about everolimus and sunitinib. And of course, pasireotide, which is a neurosomatostatin analog, and long-acting somatostatin analog, we do know that it has deleterious effect on metabolism or glucose metabolism. So based on the and on the study of the RADIANT-3 study, where patients with pancreatic neuroendocrine tumors were given treatment with molecular targeted therapy and everolimus, patients that they had malignant insulinomas, they were shown to have a response to the hypoglycemia, and that was because of the inhibition of the mTOR on not only 2 but also 1, and then by everolimus, which precipitates the increased glucose generation. And so this is a medication that we can use, and now there was a publication saying that although these drugs, they don't have a lot of reduction of tumor growth, they can still be used because of the hyperglycemic effect. And there are some data showing that patients that they respond very well to PRRT, they can reduce the insulin levels, and they can control the refractory hypoglycemia. And of course, this accounts for every other method that can reduce tumor bulk. And this is a patient that was shown to have retractable hypoglycemia and was on continuous IV dextrose, and he was hospitalized for a considerable period of time. And after treatment with lutetium and everolimus, he was managed to discharge and carry on everolimus with control of his hypoglycemia for a considerable period of time. So gastrinoma is the other relatively common neuroendocrine tumor, functioning neuroendocrine tumor. The majority of the gastrinomas are found in the duodenum, 6 to 7% in the sporadic ones, and almost all of them in the ones related to MEN1 syndrome, secreted by the G cell, and then they act on them and the stomach to produce excessive excessive hydrochloric acid, and therefore cause peptic ulcer disease and diarrhea. So the way to deal with that is to inhibit the secretion of hydrochloric acid, and this is done by the proton pump inhibitors, which can be very efficacious in the doses shown. And these have a long half-life, and they are preferential drugs. And of course, we can use H2 blockers as well if this is in several occasions. Somatostatin, which has an inhibitory effect of gastrin, of course, can also be used. And there are some compounds that they antagonize the gastrin receptor, like netazepine, but this is not still in use. We have to titrate the dose to reduce the hypersecretion to less than 10 milliequivalents per hour. And in the acute setting, we have to give high doses of IV pantoprazole. And we have to remember that we have to keep the treatment for after surgery, if this is the treatment that we have chosen to do, because they can have rebound effects. And we never forget that these patients can be present in the presence of MEN1 syndrome. We have to take that into consideration. Vipoma is a very devastating neuroendocrine tumor because it causes extreme diarrhea and dehydration. Patients can have up to 20 liters per day. We have recently a patient that he had 25 liters per day. Somatostatin analogs are the treatment of choice, but because these patients have a lot of electrolyte disturbances, they have losses of potassium in excess of 350 milliequivalent per day. We have to correct that along with the acidosis. We prefer to give them initially lactate because of the generation of bicarbonates, and we may end up giving high doses of octreotide in order to try and control the refractory diarrhea. And there are some anecdotal data saying that glucocorticoids can have an additional effect as well. And recently, there are some publications about 7 patients that they managed to control the secretion of VIP for VIPoma by sunitinib. The exact mechanism is not very well known, but according to this publication, patients that had been on several medications before, but the administration of sunitinib VIP levels reduced substantially, although there was no effect on tumor mass per se. This is a patient that we have treated, and you can see he had a VIPoma with high VIP levels. He was treated with somatostatin analogs. We increased the dose. We give him chemotherapy. We did debulking surgery, NRF, but still he had uncontrollable diarrhea. And then with sunitinib, we managed to control him for a subsequent period of time. And then he recurred. And he stayed in hospital for almost 3 months. As I told you, he had about 25 to 30 liters of diarrhea per day. And he had mostly extrahepatic disease, so wouldn't do a lot of things rather than systemic treatment. But he responded very well to PRRT, and he's still in remission. So glucagonoma is another devastating functioning neuroendocrine tumor due to the secretion of glucagon. It can cause cachexia and malnutrition and severe diabetes mellitus, and the rationale is to give them somatostatin analogs, control the malnutrition and the diabetes mellitus. These patients are increased risk of thrombosis. We have to give them low molecular weight heparin, and because they have this devastating rash, we may need to treat that with antibiotics. And this is a very impressive response to patients' rash following the administration of somatostatin analogs. We have to take into consideration as well that about 3 to 6% of these tumors, they can alter their functional status. So non-functioning ones can become functioning, and functioning can change their secretory component. So physicians have to be alert about that. And when this happens, then usually we have a more aggressive tumor developing. Coming now to the ectopic syndromes, which I think that they're going to be further discussed by the next speaker. The ones that I would like to discuss is the ectopic ACATH secretion, usually from bronchial carcinoids and from gastrointestinal neuroendocrine tumors. The ones that I'm going to discuss are usually the occult ones, that they are not associated with very severe syndrome, the one that we see with the poorly differentiated tumors. And the rationale of treating these patients is try to tune the tumor bulk, and this is not possible, which is most of the times the case. Then try and give them medication, adrenalytic, to reduce the cortisol secretion or act against the action of cortisol and the glucocorticoid receptor. But a lot of patients, they may end up having adrenalectomy. And nowadays, we do know that about 3 to 6% of apparently non-functioning pancreatic neuroendocrine tumors, they may do secrete PTHRP. And this is the action of PTHRP when instead of acting as PTH, when it comes from neuroendocrine tumors, it goes to the receptor of PTH and increases the absorption of calcium from the bone, from the kidney, and induces hypercalcemia. And this is the hallmark of the diagnosis: increased calcium, low phosphate, low PTH, and high PTHRP. And this is the treatment that we're currently using. We try and reduce the tumor bulk, and then we give bisphosphonates, glucocorticoids, and calcium mimetics as well in order to try and reduce that. And we have seen few patients that have responded to this kind of treatment. Thus, this slide to show you that PRRT are quite efficacious even in patients with lung carcinoid tumors, particularly from the ones that they have a secretory component. And in patients, in these studies that they were used in patients that they had a secretory component, they managed to be quite efficacious in controlling the syndrome. And just coming back to the end of my talk, there was recently a publication from the UK putting in line what are their guidelines in order to try to control patients and look after patients with neuroendocrine tumors during the COVID pandemic. And they categorized the matter of urgency patients in category 1, 2, and 3. And as you can see, the patients with functional tumors, because of the severity of the syndromes, are put in category 1, which means that you have to treat them urgently. So I'm concluding by saying that gastrointestinal tumors constitute the majority of neuroendocrine tumors or neoplasms, as we call them nowadays. Surgery is the cornerstone of treatment and can reduce the clinical symptoms along with calcium-directed techniques in metastatic functioning neuroendocrine tumors of the gastrointestinal and the system and the lung. Long-acting somatostatin analogs constitute the main medical treatment for the majority of functioning neuroendocrine tumors, but additional means are used to control insulinomas and gastrinoma. And treatments aimed at reducing the output is the main mainstay. So thank you very much for your attention.